Good evening, everybody, and welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Alexander Lederman from Switzerland. Dr. Lederman is a private docent at the University of Geneva. He's also the CEO of BMed, president of the Swiss Shoulder Group, and also the president of the Foundation for Research and Training in Orthopaedics, the FORE group. He's been the president of the membership committee and also the member of the Central Committee of the European Society of Surgery of Shoulder and Elbow, and also a member of the Central Committee of French Arthroscopic Society. Dr. Lederman has been the Congress President for the European Society of Shoulder and Elbow Surgery when it was held in Geneva. He's the editor of the Journal of Shoulder and Elbow Arthroplasty and has authored more than 150 publications in journals and books concerning the shoulder joint. If you've noticed, Dr. Lederman has lectured a couple of times on our channel and it's already reached a huge audience. And today it's my great honor to bring back Dr. Alexander Lederman for this wonderful live program. Over to you, Alex.
Okay, thank you so much. Again, thank you for the invitation. I think that what you are doing is simply great, and I really like this type of teaching. So thank you again, sir. He asked me to talk about advances in rotator cuff management, and this is something that is interesting because when I learned arthroscopic surgery, I began with Gilles Walch, and many things that I was doing 15 years ago with Gilles Walch, I'm still doing them. So my practice has not dramatically changed. I think that my results have improved. And the goal of this presentation is to try to explain to you why is it so. So I have some conflict of interest. I'm a paid consultant for Arthrex, Stryker, and Medacta. I receive royalties from Stryker, and I'm also the founder of a foundation for research called FORE, of a company called BMed, and also of so BMed is dedicated to teaching and med forecast to artificial intelligence. And almost everything that I'm going to say is already on BMed. So this is a free and participative website. If you want to go there, there is a wiki and everything is already reported. So this is the story of the subacromial impingement. You can actually, it's exactly the same with the cuff. This is what happened during the last 150 years ago. Simon Duplay described in 1972 the subacromial impingement. Then in the 40s, people were concerned about this possible impingement, so they began to do acromonectomy, but the results were not so good. So they then did open lateral acromonectomy, and again, results were not perfect. So in 1952, Charles Neer introduced the anterior acromoplasty, and then the team of Christian Gerber with Ralph Nifeller thought again about lateral acromoplasty, but this time arthroscopic one. And 150 years later, actually, we came back at the beginning. We still don't know if there is an impingement, if it really exists, and we don't know the role of acromoplasty. And for the cuff, it's always it's again the same. We are always reinventing the wheel, but finally with very little steps. So today I would like to talk about some study that I did about demographic factors, biology, prediction for surgery, the surgical techniques that I changed since 15 years, and particularly for bizarre condition that I will introduce to you, and then also the rehabilitation, because probably that rehabilitation has been a major change in my practice. So what about demographic factors? And we know that they are clearly important. Factor can be intrinsic, and we are thinking about age, genes, tobacco, alcohol, cholesterol, hypertension, and so on and so on. And this is interesting because everything that is good is bad for your cuff. So you can think about sports, good food, good wine, tobacco, everything that what I consider like quite good is actually very bad for your tendons. So this could be a mnemonics. And we asked ourselves some years ago if we could go to the worst case scenario, and I prospectively investigated if other enjoyable activities might be dangerous for the rotator cuff. And what we found was quite interesting. It has been published, and I think you understand why it took me some time to publish it, because some editors were quite reluctant, but we showed that some position were not so good for your rotator cuff. So today we can clearly confirm that everything good is really bad for you, and particularly for your tendons. So this was regarding the demographic data. And at least in my area, the problem is I cannot really fight against these demographic problems, because patients will remain fat. They won't stop to smoke. They will continue not to take their pills for hypertension, against cholesterol, diabetes, and they will continue to drink and to have sex. They won't exchange their genes. They won't elongate your tendons and reabsorb the fat infiltration, and they will also continue to do sport. So we really treat complicated and non-compliant patients. I think that this is a very important message, even if tons of a lot of studies have been published this last year about all these factors. Actually, we can't change everything that is bad for our patient. What about now indication for surgery? And this has been also fun. This has been a game changer for me, and I think that this is also crucial. We know that we should probably not operate patient that has a chronic acromial distance below 7 millimeters, patient that has fat infiltration grade 3 or 4, a positive tangent sign or a backbone fish sign, patient that has an anterosuperior escape, acetabilization of the acromion, and fermalization of the human head. So this is known, and we should not operate this patient, but we don't know who we should operate. And we are quite bad because we take important decision, and we have something like 20 minutes to analyze hundreds of data, and we don't succeed to identify at-risk patients, because we know that this patient, if he is a smoker, he has a higher risk. But what about smoking plus diabetes, but in a young and very active patient? We don't really know. So this is a problem. And to improve outcomes of rotator cuff repair, one possibility will be to preoperatively isolate this patient that will not truly beneficiate from a surgery. I published in 2015 that 6% of our patients still don't work at 9 months, and most of them had a non-healed tendon. And the French Arthroscopic Society published this year another very interesting study, and they found that at 1 year, 12% of the patients remain unhappy. And this is surgeons that are quite high volume surgeons, so they have some feeling. So if you are not a high volume surgeon, you will probably have even higher rates of patients that are unhappy or that does not work. So I say to myself, maybe it could be very interesting to have a machine that could help us to do the right choice. Shall I really operate this patient? And this is also interesting because it empowers the patient. Today, the patient does not understand anything, and we cannot really guide him because we don't know. If one day the machine is able to tell us, okay, sir, your patient has 67% of chance of success, then you can just say to your patient, okay, 67% of chance, what do you decide, sir? And you empower your patient, and actually you give the patient the responsibility to choose. Do you really want to take this kind of risk? So to do this, we take a quite large database, 6,600 patients. At the end, because there was some missing data, 920 patients. We had like in input columns, smoker, diabetes, classification of rotator cuff tear, the size of the tear, the retraction, and we correlate this with 2 years SANE score. We had the usual training subset, testing set, and then 20% for training data used as a validation set. And this was very interesting because we had an accuracy of 80% in the training phase. It grew up to 89% with simple artificial intelligences, so simple algorithm like a decision tree. And then when we move to deep learning, the machine has been able to tell us in 97% of the case with deep learning that this patient should be operated or not. So this is quite interesting. It's not the end. We need to improve algorithms, to develop algorithms dedicated to this kind of analysis, to medicine, because it was general algorithm. But you have to understand that in some years, a machine will be able to analyze for you these hundreds of factors and really give you an accuracy, tell you with how many % of chance of success your patient has. So this is something that is really, really interesting. Another point that I wanted to talk about is biology. Biology has been a huge hope for us. I remember in 2010, this was very, very fashioned. Everybody was talking about biology, about growth factors, PRP, and so on and so on. So I have been working a little bit about this topic, and in 2012 I began a prospective study, and I injected. For me, we already knew that PRP was not really efficient. For me, it was because there was a dilution into the joint. We were putting PRP above the tendon, under the tendon, but as soon as you remove the water, there is a flush, it's diluted in the hematoma, it's going everywhere except where it should have an effect. So I say to myself, okay, to really prove that PRP is interesting, you should inject interstitial tear, meaning that as soon as the substance, the growth factor will be in the tendon, as this is an interstitial tear, it won't be able to go away. So we did a prospective study, and what we found was that the patients were doing better. We had improvement in various scores. So we did an MRI before the injection, 6 months after the injection, and we observe an improving scores and also a decrease in tear size. It was a slight decrease. Anyway, it was significant. And the prime is, so this is an example. You see before the injection, and this is after the injection. And clearly the patient was doing better, and the bad images that we had at the beginning, they have vanished. So quite interesting. But the problem is that we didn't know if it was really the PRP, if it was the dilatation by the liquid, if it was the needling of the lesion, because when you have a lesion and you push a needle through the lesion, actually you create a reaction. So we didn't know if it was really the PRP, dilatation, the needling, and so on. So we did a prospective comparative study with PRP versus saline. 80 patients randomized into 2 groups. It was really a strong methodology, quite difficult to do. It took me several years. It has been published in the AGSM in 2019. And interestingly, we have not noticed any difference, except that PRP was, of course, more expensive than saline. And we had in this study more side effects, more frozen shoulder, and so on. And all the study that has been published since, serious study about PRP, comparative, prospective, find exactly the same. There is actually zero science behind the use of PRP in shoulder, maybe except in very special conditions. But I completely personally stopped, and I have been very deceived by biology. I tried to add a third arm to this nice study with stem cells, and actually all the company refused to support this type of study. So for the moment, I cannot do it. What about the surgical technique? So I think that the first message is single row, double row, triple row. We are tired about it. We should stop to talk about it because there is probably place for everything. I'm doing from time to time single row, double row, and it's not. I don't do the same because it's not the same type of lesion that we treat with different techniques. So for me, everything is BS. We should stop to talk about it. This is not interesting. We talk about it during 10 years. Now it has to stop. Interestingly, and I published it in 2015 with Philippe Collin in a nice study in the GSCS. We did 365 surgeries, and at the end of the surgery, we were putting a smiley on our operative report. I'm very happy with the repair. The repair was so-so. I did a bad repair. And we correlate this with the 6 months results and the healing rates. And there is zero correlation, meaning that it's not because you have the impression to have done not a good job during the surgery that your patient won't have a bad result. So I don't think that all this problem of rows or number of anchors really is a major factor. What about irreparable rotator cuff tear? Because since 2010, a lot of things has changed. And interestingly, the treatment depends on the place where patient lives. So if you live in Berlin and in Geneva with my colleague Cunningham, you may have a tuberoplasty because you want to correct the shape of the proximal humerus. In Lyon, you will have a tenotomy of your long head of the biceps. In Israel, you will have a balloon in your shoulder. In Zurich, the latissimus dorsi transfer. In Grenoble, you will have with Johan Barth a patch. In Japan, of course, a supercapsular reconstruction. In San Antonio, before the supercapsular reconstruction, it was a repair at all costs. In Dallas, even for small cuff butch, is using from time to time the reverse shoulder arthroplasty. So treatment for the same lesion. I visited all these surgeons. For the same lesion, the treatment really depends on the place where you live. It depends on geography, surgeon experience, healthcare systems, and I think that reimbursement is important. I'm living close to France, and in France, they don't have access to the Arthrex allograft because it's simply too expensive, implant cost, and also I have to admit conflict of interest because many of these surgeons that publish this technique have, of course, conflict of interest. And we analyzed this in 2018, and the results were really interesting. You can take all the surgery that I mentioned, okay, all of them, and you have a look to preoperative score, constant score, ESCS, whatever. It's almost the same, except for the reverse that has lower score. But interestingly, all the scores are almost the same. And then have a look to the postoperative score. Whatever you do, you can do transfer, you can do supercapsular reconstruction, you can use a balloon, and so on and so on. At the end, this is exactly the same. And have a look to the failure rate now. If you do a bicep tenotomy, you don't have failure rate. That's it. If you do a transfer or a supercapsular reconstruction, you have around 50% of failure rate. And this is quite high. And the balloon, as it is biodegradable, of course, you have 100%. So for the same technique, for different techniques that are not the same price, not the same difficulty, you will have the same result and clearly different rate of complication, price, and failure rate. Interesting. So today, we know that it's possible to do a superior capsular reconstruction with a patch, but also with the biceps. This has been reported by Poutsiadis and Johan Barth from Grenoble. If in massive rotator cuff tear, usually I kill the biceps. For irreparable tear, I keep the biceps and I use the biceps and try to reconstruct with these biceps my rotator cuff tear. And this is a surgery that I don't do regularly, but I did one today, this morning, and I was really happy with the result. So this is something that I use from time to time, but have a look. This is now a biceps tenotomy. It takes 10 seconds. It costs €1. And this is a superior capsular reconstruction. It takes something like 2 hours, cost €5,000 for exactly the same result. If you read carefully the literature, that's the same result. So this is a study that we published recently. We published 3 studies about the superior capsular reconstruction. The Chinese way, so with the long head of the biceps, is give quite good result for primary cases. If you don't have the biceps, you may think, because I think that the concept of the superior capsular reconstruction are now validated, you can use an allograft for a revision, knowing that you will have quite a high rate of failure. But just remember that the superior capsular reconstruction won't do a better job than a partial repair. And this has been nicely demonstrated by Stefan Greiner in the OGSM this year. So I think that you should keep it simple. What about now irreparable rotator cuff tear and pseudo paralysis? This is a case that I treated. It's a young patient with a bone loss. He has been operated in Thailand the first time. So this was the fracture. And you can see that he has a huge bone loss. And I did an arthroscopic, I tried to do an arthroscopic repair in this patient. So this is what has been done in Thailand. They tried to fix it with 2 screws. And when he came to see me, he didn't have any more greater tuberosity, and there was this huge hole. And what I did at that time, it was, I think, in 2012 or 13, I repaired the tendon in this hole. And the patient remained pseudoparalytic. So meaning, and I had very good tendon healing. I can prove it. So even if you repair the cuff in a hole and the cuff heals, it won't by definition restore the active range of motion, because the greater tuberosity, the shape of the proximal humerus, and the tension of the cuff is something that is crucial. And if you don't restore all these factors, you won't have a good result. So what to do in case of bony and tendinous insufficiency in young patients? And I had the idea, and I published it for the first time in 2016, to use a fresh frozen allograft. It's a calcaneum and an Achilles tendon. And I had the idea to use it to address these difficult conditions. So this is what I do. So you have a hole and you graft in the hole the calcaneum, and then you take all the Achilles tendon or a part of the Achilles tendon to do a reinsertion of a reattachment of a reinforcement of the cuff. So this is the supraspinatus. It's coming on the allograft, and then you do reinforcement of your tendon with the allograft. So this was one of my first patients. You see that she was pseudoparalytic. There was this huge hole. I used the calcaneum and the Achilles tendon. So you fix the calcaneum with a screw, then you use the Achilles tendon to reinforce the cuff. This is the postoperative result with a good integration of the allograft and a very good, and we review all these patients now at long term, and she still had 7 years later a very good result. This is another case. So 63 years old male, fracture 1 year ago. He had an anterior forward flexion below 90 degrees. And this is a perfect indication for me. You see that there is a grade 2 retraction of the cuff. And for this patient, this is my technique of choice. So this is the article that has been recently accepted in the OGSM. So we use Achilles tendon bone block allograft for these massive rotator cuff tears. So this is another patient, a third patient. You see that this patient has been operated several times. He had initially, if I remember well, a phyllos plate, and then the grid tuberosity went away, and he has been reoperated. It has been a failure. He doesn't elevate more than 70 degrees. This is the postoperative result. So no more proximal bone. See 3D reconstruction, and this is the video of the repair. So you have this hole, the rotator cuff is here, and then you prepare your Achilles allograft. I'm sorry. So this is the allograft. You impact the allograft, you impact the calcaneum into the bone defect, and then you will fix this calcaneum. So calcaneum is quite big, and you can reconstruct all the proximal humerus. And interestingly, you see that on calcaneum there is a small place to reinsert the rotator cuff of the patient. So you will use this small place to reattach on the allograft the cuff of your patient. Then if the graft is too big, you just use a saw to reduce the size. And then you impact this allograft into the proximal humerus, and you will use the Achilles tendon to reinforce your cuff. So I insert some anchors in the native humeral bone, and then I will use these suture to reinsert the cuff. You fix the bone graft with a screw, and then when this is done, you just cut your Achilles tendon. Sometimes to time it's too thick, so you can decrease the thickness. You just cut it, and with this graft, you just reinforce the cuff that has been repaired previously. And honestly, this provides a very, very strong construct. So something that is really, really interesting. And then I use Etibond or Etibond Vicryl anyway to reinsert this Achilles tendon on the rotator cuff. And I had the opportunity to remove screw of a patient, and I did it with the scope, and I took biopsy of the rotator cuff, and I've been able to prove that this Achilles allograft is actually alive. And we had on the biopsy that we took 63% of the biopsy that were absolutely alive. So this is really something that is interesting. And if nothing helps, if nothing is working, remember that for the cuff, from time to time, the reverse shoulder arthroplasty is just great. We develop here an approach that is called the subscap sparing approach. So we don't cut the deltoid, we don't cut the subscapularis. This patient has been operated last week, and I saw her yesterday, and you see that even at 7 days, so she never had any postoperative immobilization. She never had physiotherapy. She's just stretching by herself. And at 7 days, she already had a fantastic result. So from time to time, I think there is no use to repair everything at all costs. From time to time, if you are reasonable, you should just simply move to the reverse, because this is also a great tool. And finally, I would like to talk about rehabilitation. So this is something that is very interesting. We have more and more demanding patients. They want to return quickly to different activities. And some do not respect the rules, meaning that if you listen to a patient, at least I have been listening to my patients, and patients just say to me, okay, I'm sorry, sir, but your sling, you know, I just use it for two weeks and then remove it. And I said that there was different repair because we are treating different pathology. And for the cuff, there is several problems that we have to manage. There is the supracomal space, there is the elongation of the tendon, the traction on the repair, and so on and so on. And you need to take into account all these factors. So most surgeons prescribe a period of shoulder immobilization in an abduction pillow with the arm in neutral rotation or slight internal rotation. Interestingly, in US, it's more neutral rotation. In Europe, it's more internal rotation. And patients are advised to wear this sling or brace in the first 4 to 6 weeks. But is immediate mobilization really bad? I'm not sure, because we don't observe failure in continuity in all cases. We know that exercise and motion are essential for adequate healing of tendon, and it should be started soon after the surgery during the proliferative phase of healing. And moving a patient right after the surgery will also improve the viscoelastic properties. So it's not, according to me, a drama to mobilize patient that has small tear and a very good repair. Immobilization for this patient can be quite well tolerated. It seems quite happy. However, immobilization is not always great. There is a cost somewhere. From time to time, you need to replace the splint because they are completely destroyed. So this is all personal case that I treated. I saw everything in my practice, meaning bad positioning of the splint. This is something that we saw all the time, and these patients are not very comfortable. And interestingly, the patient have impaired gait and falls, and this is more frequent after rotator cuff, and I don't understand this, probably because of the immobilization, than after a total hip replacement or a total knee replacement. It's 3 to 4 times more than after a lower limb surgery. And finally, immobilization can induce patient frustration. They cannot drive. They have functional limitation, delayed recovery, and return to work. And this is not very good. And this is why I think that immobilization has side effects, muscle atrophy, joint stiffness, and pain. And if you could move safely your patient after the surgery, you may decrease the pain, the stiffness, and also facilitate early return to activities. So we did a study. It has been published in the GBGS AM, 80 patients that had isolated full thickness superior tear. And we divide these two groups, this patient, into 2 groups. There was a sling group, a no sling group, 40 in each group. I did personally all the surgeries during 2016 and 2017. I performed adjuvant acromioplasty if there was radiologic sign of dynamic impingement, AC joint resection only if it was painful at palpation, and a biceps tenodesis orthotomy when the posterior groove, wall of the bicipital groove was damaged. And I was, for this study, doing only the same repair with an independent double row technique that we published with Philippe Collin in 2016. And then postoperatively, a group had a sling for 4 weeks, a group no sling. They could, in the no sling group, they could not do active elevation and abduction or forward flexion. Otherwise, it was exactly the same type of rehabilitation, so passive range of motion. After 4 weeks, they were allowed to perform daily exercise, and they all had at 6 months ultrasound, and there was no significant difference in tendon thickness, bursitis, echogenicity, and repair integrity. But in the no sling group, the patient has less pain. They had, in this study, improved functionality. I know that this is not always the case, and greater early range of motion, even if the goal is not to have complete range of motion at 6 weeks, because if you move your patient too aggressively at the beginning, you may have an increased retear rate. So there was a slight difference between the group, but it was not one group that was completely stiff and one group that has complete range of motion. There was a slight difference. However, this was in this study statistically significant. So our finding corroborates other authors who reported the benefit of early motion rehabilitation protocol after rotator cuff repair in terms of greater range of motion and lower pain. There are other studies that has the same result. And now for the superior cuff with a good repair, I do not immobilize at all my patients. But if they have a subscapulaire, I put them in internal rotation during 4 to 6 weeks, depending of the retraction and the difficulty of the repair. And if I have massive posterior superior tear, I put my patient in abduction external rotation for 4 to 6 weeks, depending of the quality of the tendon, age of the patient, quality of the bone, and so on. So we have different protocols, but for some type of type of lesion, I completely abandon postoperative immobilization. So this is the end of this presentation. I know that there will be questions. For me, there is no panacea. You need to, everything is a la carte, depending of the type of lesion, the quality of the tendon, the quality of the bone, the biology of your patient. You can be very young at the age of 80, and you can be really in a bad shape at 60, smoker, diabetic, and so on. There is, for irreparable tear, palliative or non-prosthetic option that have an alarming rate of structural failure, around 50% on the short term. And today there is zero indication and there is no support to use initially complex and expensive techniques compared to simple tenotomy or partial repair. If you love good science, we organized a very good course in April 2022 in Val d'Isère. Registration are open. You should hurry up because the number of participants is growing quite quickly. And there is another great congress. Unfortunately, it's in French, but there will be some session that will be translated in Geneva in December with the French Arthroscopic Society. Thank you very much for your attention.
Thank you, Dr. Lederman, for yet another brilliant talk. There's so much to learn after every presentation.
Microphone.
Yeah, can you hear me? Can you hear me, Dr. Lederman?
Yeah, now it's perfect.
Yeah. So thank you for that fantastic talk. And there is so much to learn after every presentation of yours.
Thank you, Master.
Okay. First question is regarding the biceps. I mean, you mentioned in these slides that you use the biceps to use for the rotator cuff tear. Now, you are a big fan of how to use the biceps when you did it for instability in the form of dynamic anterior stabilization. So how is it that you use the biceps in a cuff tear? How is it? What is the technical strategy?
Yeah. So as soon as when I treat a big tear, when I plan my surgery, I always write down, be careful, it might be a superior capsular reconstruction, because usually when I do a surgery, one of the first things that I treat is the biceps. And you know, I'm close to France, so usually I cut it or I do a biceps tenodesis. But for these massive tears or irreparable tears, I keep the biceps. So I write on my planification, do not cut the bicep right now. And then I test the reduction of the cuff. If I have any doubt, if there is too much tension, at this moment, I put an anchor that I implant in the middle of the footprint, something like 1 centimeter posteriorly to the bicipital groove. And I pass suture around my biceps. So I have a lasso and then a suture that goes through the biceps to have like a ripstop configuration. And I tighten my suture, and this will actually translate your biceps in the middle, just above the top of the human head. Then I fix it and I cut the biceps distally. And at the end, you repair all the curve that you can. So today I've been able to bring all the infraspinatus at its place. And so it was a L-shaped lesion. So I took the infraspinatus, bring it back on the footprint, and I put some additional suture between the infra and the long head of the biceps. Patient then in abduction during 6 weeks and a gentle rehabilitation.
And Dr. Lederman, have you published this particular technique where you've used the biceps to bridge the defect in a cuff tear? Because you've published the other one, right?
So this is one of my friend, Johan Barth, who did it. Johan did unbelievable fellowship of the French Arthroscopic Society in Asia. And he saw some Chinese that were doing this technique. And he published this technique with these Chinese. So it's why we call it the superior capsular reconstruction, the Chinese way.
Thank you so much. Okay. The other question is, see, you've mentioned the technique where, again, you've used the Achilles tendon as an allograft. And is it published? Have you published that? And what is the experience of the other authors who have published in case they've done it?
So there are several publications. We published the, I would say, the technique in the journal of the, it's a KSTA journal in 2016. And then there is in press, so it has been definitely accepted in the OGSM, the 2 years result. We have a result between 2.5 and 10 years. 10 years. And interestingly, we had on this series, it's a small series, 5 cases, but 4 of the 5 are doing absolutely well. And one patient had, it was a proximal humeral fracture that failed with a bone loss. And actually I repair the, I did my allograft, but the patient continued to have an osteonecrosis of the humeral head that he didn't have at the beginning. So we had to put a reverse in this patient. And this is the only failure. All the other patients were doing well. And it's not a failure of the graft, it's the osteonecrosis of the humeral head that continue.
And just one technical question about this. Do you attach the tendon to the superior part of the glenoid, like how you do in superior capsular reconstruction?
No, I don't do this. And there are also publications that use my technique to do superior capsular reconstruction. So they use an Achilles tendon and a calcaneum allograft. And actually they fix the tendon on the superior glenoid and it failed. It has been published in the OGSM as well. So this is not a good technique at all.
So how do you get it to the, you repair it back to the remaining cuff, is it?
So I repair back the remaining cuff on the calcaneum allograft, and then I use the Achilles tendon above this cuff to cover my cuff to do a really strong reinforcement.
Thank you, Dr. Lederman. Just one last question before we wind up the session is regarding the sling versus no sling. And that's another fantastic paper from your side. And you mentioned that you don't use a sling for a select subset of patients, right?
Yes.
And what is that particular subset?
So it's all patient that has a superior rotator cuff with a good fixation. If the quality of the tendon is good, if I'm happy with my repair, I don't put any sling for isolated supra or even large lesions, so meaning supra-infraspinatus, but it doesn't have to be massive lesion. Why do I do this? Because we published in 2018 an interesting study, and we analyzed the lengthening of the cuff when you move your arm. So for the supraspinatus, as soon as you move your shoulder, the length of the supraspinatus, meaning the tension of the on the repair, decrease. It's very interesting. You have to remember that the supraspinatus is the only tendon in your body that is in maximal tension at rest. When you have your elbow at side, it's under maximal tension. So as soon as you move, the tension decreases. This is not the case for the subscapularis and the posterior cuff. The subscap 115%, the teres minor 132%. So as soon as you move either the anterior or the posterior cuff, the tension is too important, and you may end with a failure. So be careful with anterior and posterior cuff. For the superior cuff, honestly, I don't care. I'm working on the result of the midterm result of all these patients with no sling to prove that they continue to do well. It's going to be in 2022.
Thank you, Dr. Lederman. A fantastic lecture, a lot of new learning, and thank you so much for joining with us.
It's always a pleasure. Thank you so much.
Bye-bye.
Bye-bye.